Hereby I open this academic ceremony in which Francisco Contreras Ruston will defend the academic thesis Self-Voice Awareness and Sensory Feedback in Parkinson's Disease, investigating the missing link between voice changes, self-awareness and sensory feedback in Parkinson's disease. May I invite you to present a summary of your study and the conclusions of your thesis.
Thank you. Highly esteemed colleagues, directors, members of the opposition, supervisors, friends, and family. Thank you all for joining me in person and online for my public defense on my dissertation entitled Self-Voice Awareness and Sensory Feedback in Parkinson's Disease. Over the next 15 minutes, I will present my thesis. Parkinson's disease is a genetic brain disorder that presents motor symptoms, which are the most visible, and non-motor symptoms, which also play a fundamental role in quality of life. What about the voice? Is also affected, but both regarding motor and non-motor symptoms. I would like to explain there are two systems related to voice perception. One of them is bottom-up. The sensory feedback runs into the background, sending information back to the brain to fine-tune loudness and pitch in real time. On the other hand, the top-down, the brain sends motor commands to produce our voice. We engage in self-voice awareness, how we think when speaking and giving a context, and how we judge our own voice. Now, what happens when one own voice perception is affected? This is the case for individuals with Parkinson's disease. I will start with self-voice sensory feedback and then to move to self-voice awareness. When we speak, our brain predicts our own voice should sound like in pitch and loudness. Then the sound reaches our ears and the brain compares which is here and what is expected. This is my voice loudness, and this is my voice pitch, and this is my voice should sound. But if the voice breaks, the brain detects a mismatch between how it sounds and how it should sound. That triggers rapid adjustment to bring the voice to user and patterns. And all of this happens within a millisecond without us to having thinking about it. How can we measure this? By comparing cell-generated voice and the same voice as heard externally or passively. Both the prediction and the outcome of the prediction can be shown in event-related brain response during the GE measurements. To interpret this, we focus on 3 brain response for stimuli. In this case, to one on-voice stimuli. In P50, it's associated with early filter of the signal, while N100 capture for early perception, and P200 evaluation of the voice. For example, when the sensory feedback of one on voice is fully expected, the N100 response is suppressed, and that is the dashed line. Compared to just to listen on to one on voice, that is more negative response. That is the red line. The difference between these two physical identical voice sounds is called the N100 suppression effect. Our voice sound different. For example, when the sensory feedback is fully exchanged, one will assume the suppression effect will decrease and the response to one of sensory feedback increase. And this could be different in people with Parkinson. Voice awareness is more than hearing ourselves. We pause, notice changes, and evaluate our own voice. First, we pay attention how the voice sound and how the sensation feel when producing our voice. Then we try to understand why the voice sounds a certain way. Next, we judge whether the sound of the voice is appropriate for the situation. And finally, we form a personal evaluation of it. How can we measure self-voice awareness? One key tool is PROMs, Patient Report Outcome Measures. These are questionnaires that report whether individuals perceive their voice difficulties and how these difficulties affect their daily life. PROMs typically cover functional impact, like phone calls, emotional impact, and also physical impact, like discomfort. In clinical voice assessment, prompts are useful because they show whether the person actually perceived the problem. However, these tools were developed for general voice disorder, not for Parkinson-specific voice characteristics. What is the voice paradox in people with Parkinson related with the voice? Around 89% of individuals with Parkinson have hypokinetic dysarthria. This is a Parkinson-related speech disorder that typically leads a monotone voice, imprecise articulation, and low voice loudness. In fact, 70 to 90% of the people with Parkinson show impairments in voice loudness. They may also have difficulty to perceiving their own voice in real time, but most of the studies focus on this on pitch and not loudness. Moreover, many individuals with Parkinson are not fully aware of these voice changes. The focus of my PhD research were understanding how individuals with Parkinson deal with voice awareness and sensory feedback, and we will discuss in the chapter 2 and 3, and as well understanding the role of sensory feedback in voice production, and which I discuss in the chapter 4 and 5. The chapter 2 and 3 are related to self-voice awareness in Parkinson's disease. I will explain a little about that. In clinical voice assessment, when we administer different prompts to individuals with Parkinson, their score often fall within normal range. This suggests that many patients are not fully aware of their voice difficulties. And this is different from objective measures, such as voice recording, that show changes in acoustic characteristics of the voice, such as loudness. In the chapter 2, we test whether this instrument captures voice awareness. We administer the vocal symptom scale, measure voice intensity in 2 groups, general voice disorder group and Parkinson's disease. In the Parkinson's disease, the severity of the disease was 1 to 3 on a 5-point scale. And then we ran a principal component analysis, which explored possible similarities and differences between groups, and found significant difference between groups with some overlap. In this scale, higher score mean worse self-perception and more symptoms. The cutoff distinguished healthy individuals thus voice disorder is 35.5. And most individuals with Parkinson is scored below it, with lower scores across all domains. In the chapter 3, we address 2 questions. Do other adults report frequent complaints, or is an issue with the instrument? To address this, we assess 2 new groups and add a healthy age-matched group, and also include 2 new prompts, the voice handicap index 10 and the voice-related quality of life, and also measure voice intensity. Using the same analysis in chapter 2, the most of the individuals with Parkinson clustered together with some overlap with general voice disorder, while healthy participants form a separate group. Overall voice perception was worse in general voice disorder, best in healthy participants, and individuals with Parkinson fell in between, yet much closer to healthy participants, often even within normal ranges. Across chapter 2 and 3, the findings are consistent. This lack of voice awareness isn't explained by age alone, it's not driven by any single prompt, and more likely this questionnaire misses specific factors, such as sensory changes, that change how individuals with Parkinson judge their own voice. So, is it appropriate to use this instrument in people with Parkinson? Moving on chapter 4 and 5, we will discuss sensory feedback in Parkinson's disease. In this chapter, before the experiment, we record each participant's voice in the first session. In the second session, the previous recorded voice was played back in the N100 suppression paradigm. is into divided in 3 blocks. The first block is the auditory motor condition block. The participant tap a button, triggering a playback of their own voice in normal loudness and in plus 15 decibel increase. The second auditory only condition block, they listen the same voice stimuli at normal and plus 16 decibel increase without tapping the button. Third, the motor only block, they tap the button without hearing their own voice. This is allowed to subtract the motor activity of tapping, so we could compare auditory motor condition with auditory only condition while controlling the motor activity. We analyze group, condition, and loudness. And the results show no difference in N100 suppression effect between healthy participants and individuals with Parkinson across loudness levels. However, we did observe significant effects of loudness. People with Parkinson's disease show a more enhanced N100 response than healthy controls when the sound is passively or externally, and the loudness change. This suggests increased auditory sensitivity to changes in voice loudness. The significant results are in N100. Prior work has reported N100 suppression effect in Parkinson, but does study mainly same pitch and not loudness. In our result, Parkinson's disease showed auditory hypersensitivity to change of voice loudness, which suggests an alteration in perceptual processing of one voice is presented externally or passively. Overall, this issue seemed to be how self-voice is processed during the passive listening, especially with higher loudness. So the problem may not be sensory feedback in Parkinson's disease voice production. In the chapter 5, we review literature of sensory feedback on one-on voice and in Parkinson's disease, and the evidence still limits only 24 studies and only a few exams, for example, 70 behavioral study and a few exams EEG and fMRI, 4 EEG and 3 fMRI studies. And when we bring emotions, when pitch modulation are essential, a key gap remains. We still know little about how reduced modulation in Parkinson affect vocal emotional expression. First, the EEG finding across the study P200 often shows an increased response to pitch modulation in Parkinson, and these results are fairly consistent, while the N100 results are more mixed and sometimes is controversial. The fMRI studies suggest reduced engagement on motor cortex and basal ganglia during the speech. And there are also evidence of increased auditory cortex involvement which relate to pitch variability and loudness control. However, we still see two clear gaps remain with Parkinson: emotion-related vocal modulation and voice loudness perception linking with sensory deficit. To conclude this presentation, in Parkinson's disease, voice intention and actual output are not aligned, especially with loudness. And awareness of one-on voice deficit is also reduced. This is demonstrated in this thesis with the prompts. The ERP suppression during cell-generated voice is maintained. However, they show hyperreactivity when they hear their own voice externally or passively. This could have an impact on vocal intention, especially with regard with voice loudness. So, again, it may not be limited to sensory feedback per se in voice production in people with Parkinson. And future instruments for measured voice should take in account the deficit in voice awareness and sensory deficit associated with voice production in individuals with Parkinson. And finally, an important step to understand why only voice perception seems to change in Parkinson's disease, and whether this could become an early marker. Thank you very much for your attention, and here I give the word back to the prorector.
Thank you very much for your presentation. The opposition will be opened by Professor Jansma, Professor of Cognitive Neuroscience of Language here at Maastricht University.
thank you, Pro-Rector. Dear candidate, first of all, let me congratulate you and also your supervisor team here in Maastricht and Barcelona, if I am correct, for this wonderful work. I read your thesis with great interest, and I think what you show here is a very nice example of translational cognitive neuroscience, where you basically combine clinical expertise and fundamental information processing research in the brain. So I always like to read about that. And also in your thesis, I think you showed a very great background in different sets of methods and also theories on Parkinson. I especially enjoyed reading about the biological underpinning of the disease, and learned again an update on that, so highly appreciated. You also published already, so I see that there is a very high international link of your work, so I think you can be proud. But I also would like to ask some questions, and my question relates to chapter 4, that's the EEG study. And there you used the so-called, we always call it Knolle paradigm. So that I semantically mix Francesca Knolle with Francesco, that's also interesting. So, but the Knolle paradigm is an interesting one, of course, and it provided a lot of data on how one could investigate and interpret sensory feedback and sensory-induced inhibition, especially in the N100, I think. And what is very nice is that you pushed the P50, the N1, and the P2 into the same thing. Very, very nice. But sort of, it's a paradigm that's not really natural. So, and my question now would be: so could you give your view on the limits of this paradigm when it comes to studying sensory feedback in a speaker?
Highly esteemed opponent, thank you for your compliment and your question. Let me think. This is a very interesting question. This is a question was during also when we did the experiment. One of the reasons in people with Parkinson they have problem is also in the spontaneous speech. So maybe that is also a limitation for the paradigm. Mm-hmm. But this paradigm is possible to see very clear and without artifacts. That was we choose this paradigm. We clean the signal of the EEG with the paradigm to compare the button press, and in this case, vowel A is very short, I know. Oh. In the future direction, I would like to extend for another kind of stimuli, maybe spontaneous speech, but for the beginning to understand the problem in people with Parkinson, this is a good option to show what happened when they perceive their own voice.
Yeah, so it's no doubt that for the beginning it's a good paradigm. And also you mentioned the artifact that we face when people move their mouth or laugh, and it's a drama for the EEG. At least it has been a drama in the past, but there are probably more recent methods where you could deal with artifacts. Do you have any ideas what you would do in the future?
Well, really, the last year I read an article. It was super interesting article. The Mark Sato, and he and her team with Tremblay, the first author, they did this paradigm with the speed, but the speed very low, without force. And soft voice, and that maybe reduce also the artifact.
Yeah, I see. Oh, no.
And also another possibility is to record before the voice and the task, and after the analysis, rest that motor activity.
Yeah, it's clear. Okay, but then, like again, related to chapter 4, so you have these 3 conditions. It's this auditory motor. Then the motor only and the auditory only. So I got from the description that you use a cue.
Yeah.
Actually, you get the subject gets a cue, and then they press the button, and then the stimuli gets released. but I couldn't find what you did for the auditory only. Is that also triggered by a cue or not a cue?
The trigger is the same of the auditory motor condition, the stimuli.
So do you present a cue in the auditory only condition? That's my question.
Let me see things. No, we don't present a cue.
So
the cue in the screen was only a hand, no, a cross, and that's it.
But not the cue as the cue for the motor conditions.
No.
So I'm asking because we used this paradigm in the past, and then what we saw in the EEG, like at the moment when the cue was presented, a huge cue effect. Probably then 1 second before you get to the target epoch of your stimulus of interest. And the problem is, might be in your paradigm that you have 2 times a cue effect, and in the auditory only there is no cue effect. So I wonder whether this caused a problem for you, whether you saw it, and how you dealt with it.
Yeah, in the screen in the paradigm, the auditory only condition was only a cross, and maybe that also avoid at least the question you are talking about with me. But that's a good question, really. No.
Yeah. Okay. It's good. Do I have one more? But it's a more general one, because you also say the Parkinsons judge their voice differently or as better quality as it actually is. But I only anecdotally talk to Parkinson patients, and they first describe this when they actually walk, so that when they lift their feet, they have the impression, when they have to move and walk up a stairs, that they actually have the impression that the foot is always higher than it actually is. So that is very similar to what you described for the voice perception. So my question is, when we believe in a feed-forward model and sensory feedback processing, how general is this, or is this also very specific for language in these patients?
That's a good question. I think so. It's both. For the moment, I think so. It's not really clear related with the feed-forward model. In my results, show that it's not only sense of feedback per se. So maybe we need to know how to incorporate this part of the cue, the sensory input, in the model, and how that converges with the prediction.
Yeah, and also correlate eventually other motor aspects with the voice aspects, and see whether there's actually a straight line then, that this is all sim. But I think my time is up. So thank you very much for your good answers. Thanks.
Thank you very much. The opposition will be continued by Professor Bonte, Professor of Cognitive Neuroscience of Language and Literacy Development at Maastricht University. And she's also the member of the assessment committee, just like the chair next to her, which I forgot. Go ahead.
Thank you. So first of all, I would also like to congratulate you and your supervisors here and online with this interesting thesis, and I very much enjoyed reading it, and also really would like to compliment you on tackling a clinical challenge with different types of different types of methods. So this patient-reported outcome measures and the EEG, and then also integrate them in your thesis. And I think you managed to do so in a very coherent way. So that's, I think, really, my compliments for that. And my question then also focuses on the integration of these methods, but then also especially to the clinical translation, because in your discussion, general discussion. You mentioned that the data that you collected are essential for these individualized tools, diagnostic and therapeutic tools for the impaired self-regulation of the voice loudness or vocal loudness. So a first very general question would be, is whether you think that your results, the ones that you report, can already be directly used to inform these tools? And if you think so, how and which specific results?
Okay. Thank you, hello opponents, and thank you for your compliment and questions. I will start first with voice awareness and the prompts, and after with the EEG. I think so. My results is part of the beginning to understand this kind of tool doesn't work in people with Parkinson. These tools was developed for general voice disorders, and in the develop this instrument, they don't incorporate patients with Parkinson, only a few, one of them. So that is an issue with this instrument, and maybe that people, the results and the score don't represent really is the voice in people with Parkinson. So, in understanding this, it's possible to understand we need another kind of instrument for these people related with prompts. For example, I have an idea, I hope to do in the future, to do a new instrument to multi-informant instrument. What mean? For example, a few questions, the people with Parkinson answer, and the caregivers, and also the clinicians, to understand the whole story, why is the person with Parkinson, how is the voice, and how they not perceive their voice. This is for the part of the prompts. In the case of the EEG, is more related and regarding to understand which is the way we need to develop or develop a new equipment or treatment, or maybe to only understand what happened in people with Parkinson, and then why then don't perceive their own voice than really is. But this EEG result also is a little connection with the awareness. What mean? Because maybe it's a speculative way, it's not part of my thesis, but maybe there are not an update of the information across the time. This information go to information of the awareness and the metacognitive things. Yeah. And this to understand.
Yeah, and if I can, thanks. Yeah, that's clear. And then, so if we look then specifically at the EEG results, right? Like so in chapter 4, figure 2, there you have these nice plots also of the individual amplitudes in the different conditions. And there actually you see a group result, which is as you discussed in your very beautiful presentation. But you also see quite a lot of individual variability in the direction of the condition effects, right? Also, so not only in the healthy controls, but also in the Parkinson's disease individuals. So if you were to use these type of measures for your clinical tool, would you think that you could basically make an direct translation of the direction of the effect? So some people show the suppression, others don't, right? So can you make a translation from these type of results to your clinical practice or clinical tool, or?
Yeah, this is a good suggestion. And also, thinking about this kind of result, well, the the group control their aging. It's older people, but the result for not for developers to understand how what happened in people with Parkinson with the sensory feedback is maybe a possible to marker to understand early marker to understand how is developed or how is how is it's possible an early marker to identify people with Parkinson before to diagnostic.
And do you think then that this basically that maybe it's a related question, but do you think that this individually determined N1 amplitudes, they are reliable measures, so that indeed you can on the individual basis say if you have a larger response in, for example, the audiomotor normal condition than in the audiomotor louder condition, then this directly means something different for the processing of that individual than if you have the reverse pattern? So can you go, is it reliable enough, in your opinion, to take these individual differences or individual patterns and then use them as biomarkers?
It's a possibility, but I don't know really how we'll go with that possibility. But
because because I know that in principle the general ERPs, right, the group average, they look always very smooth. So I normally look at children's data. They are super variable in the individual level, individual participant level. And I can imagine that in individuals with Parkinson, that will also be the case, right? Or maybe also in healthy controls. So that if you look at the group average, you get really clean responses. But if you look at the individuals, there's also quite some variability and also a choice of saying, okay, within this window, I call it the N1. Maybe sometimes the N1 has 2 local peaks, and which of the 2 local peaks do you take then? And so do you see that variability in your data? Or do you see really clean responses and you say, okay, no, these differences are really reliable and therefore I can really directly use them as biomarkers or for clinical translation?
Well, the variability of for each individual, there are a lot of variability in these people, more than healthy controls.
Yeah.
So maybe that is also a kind of marker to this kind of variability you mentioned.
Yeah. Okay. And I think I have 1 minute for one last.
Keep it quick.
I can also just give you 2 if.
No.
Yeah, okay. Okay. And one other thing I was wondering about is in the same figure, you see that in the, I wonder whether you also looked at the later time windows. Because you seem, at least visually, it seems that after like 350 milliseconds, in the auditory motor condition, you see a differentiation in the responses for the healthy controls, and that differentiation is absent in, visually at least, in the individuals with Parkinson's disease. So I was wondering whether that might be an interesting differentiation and whether you have looked at them or would like to look at them.
Yeah, there are differentiation, but in my thesis, the analysis was 3-way interaction. So we have kind of 2 interaction. Maybe it's possible to study these 2 interactions, but in the case of the loudness, we did the analysis with 3-way interaction.
Also in this later time window, after 350 milliseconds.
The 50 milliseconds?
Oh, 350. So I mean that in the figure, the last part of the figure.
The last part of the figure.
Yeah.
Okay.
So not in the responses that you analyze, but in the later.
Totally true. Totally true. This part of maybe there are some kind of difference, but was not part of my thesis. And this may be also more related with evaluation of the voice.
Yeah, exactly. Yeah, thanks.
Thank you very much. The opposition will now be continued by Professor Balaguer, Professor of Psychology at the Catalan Institution for Research and Advanced Studies at the University of Barcelona, and she is with us online. Please go ahead.
Thank you very much. Thank you for the invitation to be part of this committee. This is a very interesting thesis, and I would like to congratulate both the candidate and supervisors for this very nice work. I think it's very interesting, and it's not that common that we have this translational kind of thesis where there is an interest to really understand how basic research can inform clinical practice, and this is, I think, very, very interesting. Of course, the papers, the data is also published, so I think this is also an additional interesting part of the thesis. And I also like the fact that there's an effort to have a review as well within the thesis that I think is also very, very helpful and shows how the candidate is able to integrate the work within a larger literature, and how this can be can have a potential interest at a broader sense, not just within the thesis. So that I think is very, very interesting. I wanted to ask you a couple of questions. I wanted to ask the candidate about a couple of questions, more or less general. So some of them overlap a little bit, but I think that I would like you to go further into the explanations that the candidate gave. So first of all, I really like this perspective of the thesis that looks at the multifactorial source of the problems that the patients have in their awareness of the deficits. And one of the things that is mentioned in the studies is that there is an inclusion of an interview. Actually, you do mention this in the response of the previous opponent, where the candidate includes the voice habits of the patients. I was curious to understand how does the voice habits, what was meant by the voice habits of the patients, and how does this integrate within the awareness or the sensory problems that the patients may have. So there's probably something about it, and that's why it was introduced, but I would like the candidate to develop why was this involved.
Highly esteemed opponent, and thank you for your compliment and question. Well, this is an interesting question, the voice habits. The voice habits is closer to the voice behavior. If, for example, every day I yelling, that is a kind of voice habit, and that's modify and voice behavior, and it's possible for a person to increase the loudness in all the time, and that maybe cause a damage or a lesion in the vocal folds. So when in the prompts, when on the interview, we do question how the voice habits is to exclude. In the case of my thesis, is to exclude these habits and not, maybe it's not a confounder of the results in my analysis. That's why we did that kind of interview in my research. But because the voice habits also kind to provoke a kind of dysphonia if I have a dysphonia, or the people have a dysphonia, the result in this research could be different, because the intensity also is different and the perception also is different.
So just to follow up and understand, so the idea to include that was to have an exclusion criteria, or was there any way in which this information was used in the studies?
This information only was used to understand if they have a voice disorder in the case of the Parkinson disease, but not related with the voice, not related with the Parkinson disease, because Parkinson disease, that they have a voice disorder, but not like to general voice disorders. And the most general voice disorder, they have this kind of habits or voice behavior. That's why was a exclusion criteria to understand in the case of Parkinson's disease.
Okay. Then I wanted to ask you also about your view on your results. Yes, so you have this EEG paradigm that is giving you specific results on the patient, so significant results on the way the patients have altered responses in the paradigm, and you have at the same time this limitation for the prompts that you usually apply in clinical practice. So I wanted to ask you whether you think that one possibility, would it be helpful to have this kind of more objective measures that are actually influenced also by the perception of the patients, instead of using the prompts? Do you think that would be in the future one possibility to substitute these prompts by these more objective measures that are somehow also influenced by the perception of the patients?
I understand. You mean, for example, to use the kind of measurement, the EEG, for the clinic, no?
Exactly, yes.
Yeah. I think so. There are kind of research now working to apply this kind of instrument in the clinic, but only with basic EEG measurements, because maybe this kind of instrument is possible to use, for example, like a neurofeedback in people with Parkinson, and understand, for example, if they have this voice perception is more affected than other, because people with Parkinson, they have also super variability between them. Not all they have a worse voice than others. So, and also that may to understand how will be the direction of the treatment in the voice treatment, and also to the direction of maybe for the medication, but that is a speculative way related with this information, because the medication in Parkinson don't work well in voice. Some of them works and some of them no, and that maybe with kind of information we can to understand why this medication doesn't work in some of the people with Parkinson.
And just to finish, I wanted to ask you about the interpretation of the data. It's somehow related to your what you mentioned about this biofeedback possibility of training the patients. Because if you train the patients with this kind of biofeedback, I wonder whether you are actually training attention. Yes. So, and this goes back to my question. So, in your interpretation of the results, you talk about this altered sensory feedback processing, but at this end, you somehow say that, well, you don't discard completely that there's an interpretation based on attention, but you prioritize the interpretation based on sensory processing. So how do you think that attention can have an effect on the results that you have, given that the early components where you have the modulations are components that are also affected by attention. And actually sensory processing is affected by attention. So how would you put into the system the interpretation of attention?
Well, really,
mechanisms?
in my thesis, I think so. This was a limitation. The attention wasn't there, but we tried to mitigate that in some way. We did, for example, the same stimuli is not different across the, for example, in the paradigm, only the difference between loudness. Also, we in the screening we apply MoCA. It's a test into the MoCA. They have a part of the test attention, and the other, and this part, if for example the score of the LoCA is lower, that person with Parkinson was not included in the investigation, in the research. So the attention wasn't there. Maybe there are components of the attention in the response, but we need, for example, for future direction or research, to incorporate kind of a task before to perform another question.
Thank you very much. We would like to proceed with the next opponent. Thank you very much.
Thank you.
The next opponent is also with us online and is also, just like the previous, member of the assessment committee, Professor Papagno, Professor of Neurology at the Center of Mind and Brain Sciences at the University of Trento in Italy. Please go ahead.
Thank you very much. And thank you for giving me the opportunity to read such an interesting thesis. And congratulations for all the work, the amount of work that you have done, and for the analysis that you have performed, and to have considered such a topic, which is certainly of interest, and it is not so frequently discussed and investigated. My interest is mainly on the part concerning awareness, as you mentioned before. I wonder, my interest is in fact that you talk about the fact that there is a sensory feedback and a lack of awareness of this problem of voice. I wonder if there is also a central component, such as in anosognosia. So I couldn't understand if you include in the possibility of the deficit due to awareness of voice, also the possibility that it is at a central level an inability to compare what they hear with what they expect to do, to how would be their voice. I hope it is clear what I mean.
Yeah. Highly esteemed opponent, and thank you for your comprehensive questions. That is super interesting question. Maybe they have a kind of also anosognosia related regarding with the voice. But awareness is very huge to define, because, for example, it's possible to have awareness after the task. I'm thinking about it, how it will be my voice, how was my voice. But also, it's possible to a few days after, and that is another kind of awareness. And there are another components with this kind of awareness. In my opinion, awareness is have a multi parameters into the awareness. One of them is the sensory input, the cognitive information, and there in cognitive information, maybe that is part of the anosognosia with the voice, and motor action with the voice. What means related with that? When we produce our voice, we feel sensations, how is the sound, how is the somatosensation of the voice. And also that also a kind of information on how is the voice when we produce a certain sound. I think so. I super agree.
Because you know there are some studies. Perhaps you are aware of these studies on Parkinson's disease, where on voxel-based morphometry, where there is a reduction of the volume of the insula, and since the insula is considered important in comparing what is the expected external the result, or what is your expectation inside. The possibility is that they could not match the result of their production with what they imagine they expect to be. Okay, so you think that there could be also this kind of component, so such a sort of lack of comparator between the result and the intended action, the intention and what it results. Do you think that it is possible that it is also a lack of comparative
with
aspect between what is their production and what it is expected? For example, one possibility that is suggested in hemiplegia, they know that they can move when they have anosognosia. People having anosognosia for hemiplegia think that they can move their knowledge is that they can move an arm, and but they do not compare with the fact that they do not in this case, because they have hemiplegia. So there is not comparison with what they know that they can do and what is the actual possibility to perform something. So I wonder if this could be also applied to voice. So they expect to know to speak in a certain way, and they are not able to compare to the fact that the results of their action is not the expected one.
Yeah, I agree with you. Maybe that also is possible affect the response in the case, for example, the prompts.
Okay.
Yeah, but
and another question that is before you were talking in the previous question, you were saying about the fact that drugs are not effective on all the symptoms, of course, and not, for example, on voice. So in this way, I wonder, did you find that some of this problem with voice were more associated with a type of Parkinson's disease, for example, the rigid form, which also has much more frequent cognitive disorders than with the tremor 1 form, or you didn't have the opportunity to check if voice problem was associated with one type of Parkinson's disease than with another one?
Yes.
Keep the answers short, please.
Yes, there are difference between this subtype of, for example, in Parkinson, in the kinetic or non-kinetic. The voice is different. And also the loudness is different.
Which one was the worst one?
The worst is people the Parkinson not kinetic, but not kinetic. Yeah, they have worse voice.
Okay, thank you very much.
Thank you very much. The opposition will be continued by Dr. Schwarze, Associate Professor in Neuropsychology at Maastricht University.
Dear candidate, also from my side, congratulations on a wonderful read and wonderful thesis to you and your supervisors. Well, a long time ago, before I entered any EG lab, I studied speech and language pathology, so this was also a really nice link back to some original motivations. Yeah. With my questions, I would like to push you a little bit further on the interpretation and, well, the discussion of attention and the role of attention in this, because you close the whole thesis with a statement, if a change in the voice is not perceived, no adjustment is made. So along these lines, basically. Whereas in chapter 2, you have what I thought would potentially be even the most interesting population in a way, because there you have a good subset of participants, patients with mild cognitive impairment, actually. But you're also stating sort of that there is previous research that suggests that mild cognitive impairment does not really seem to affect the type of tasks that these patients perform. On the other hand, we know that Parkinson's disease can affect attention, particularly divided attention and multitasking, while mild cognitive impairment can also affect auditory processing. So it seems to me that this group in particular would be very interesting, because the way that you introduce also speech processing, it seems like a division, also a division of potentially attentional resources between production, sort of focusing on what one wants to say, and the monitoring aspect, sort of dividing attention to, the monitoring on and the feedback as such. So it seems to me that that's a divided attention task to a degree. So I was just wondering, what is your take on this? Are these potentially patients to follow up upon, and this aspect of divided attention in particular?
Highly esteemed opponent, thank you for your compliment, your questions. Let me think about it. That you mean in my sample size or in?
Yes. So if this is something that is voice specific, yes, that's one thing. But on the other hand, it could be something more general in the sense that it affects attention and the allocation of any attentional resources between production and perception. And we know, for example, that sounds that are attended to are perceived as louder, and here it might be sort of the opposite. So something which is not attended, where not so much attentional resources can be deployed potentially, so the hearing, the monitoring aspect might be particularly affected.
Yeah, I agree with you that maybe it also affect, for example, in the chapter 2, maybe also it's possible to, the response will be different if the people have a kind of problem with attention. Mm-hmm. So because also in the prompts there are items into the prompts to, for example, to how other people perceive your voice. Mm-hmm. And if I have, for example, attentional problems or deficit, not that for me doesn't care if, for example, another people or not understand me or not. Mm-hmm. And and this is the case, that's kind of items that person put a higher score, and the result is different.
Okay, interesting. Yeah. Okay, so and then also maybe related to what I said earlier. So you relatively late mention programs like Lee Silverman voice treatment, which I would say is still sort of the gold standard in the field, and it essentially is a very intense program that asks you to speak loud, and you very much train this for at least 4 weeks, 16 sessions or so. So in a sense, training people to almost shout. Right? But it is very effective in many ways, right? And I was just wondering how very concretely you would see how your work could inform such a program, maybe optimize it further.
That is a very nice question, really, because I think so. This kind of information also is possible to improve this kind of treatment. For example, I applied this kind of treatment, Lee Silverman, and also Speak Out is similar, but the focus is a little different. But when this kind of treatment is applied in people with Parkinson, some of them say, this is a lot of effort to doing this voice loud and repeat every time, and sometimes that generates fatigue.
Right.
and boring also for the people. So the focus
Francisco Contreras Ruston, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return in this room. Francisco Contreras Ruston. The degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Kotz is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Please all rise. Do you promise to work in accordance with the principles of scientific integrity? It's not working. Okay, thank you. So I start again. Sorry about that. Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Francisco Javier Contreras Ruston, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university. I will immediately continue with the laudatio. Dear Dr. Francisco Contreras Ruston, I'd rather continue as Pancho. Distinguished colleagues, friends, family, and most importantly, Pancho, the man who proved that if you send enough polite, well-timed emails, eventually someone will let you play with their EEG system. My journey with Francesco began in February of 2021 with an email chain that serves as a masterclass of academic persistence and Chilean charm. While the rest of the world was still navigating the fog of a pandemic, Francesco was busy sliding into Sonia's inbox with a deceptively simple subject line, a question. He wasn't just looking for an advisor, he was looking for a stage to combine his fascination with vocal tasks, reward systems, and the clinical reality of people living with Parkinson's disease, who in the long run lose their ability to communicate effectively with their voice. Francisco arrived with a CV so comprehensive, it practically had its own zip code, spanning from Chile to Brazil to Barcelona. He was already a speech and language pathologist and a veteran of the Voice Foundation. Yet despite these credentials, he remained a student who was never tired to learn more, a quality that made me say, yep, let's do an EEG study. This tireless drive was backed by serious grant efforts. Francisco secured significant funding from the National Research and Developmental Agency, bringing 67,000 euros for his doctoral studies, and even before that, 16,000 euros for his master's degree. His academic output has been equally prolific. Francisco has authored numerous publications focused on the cross-cultural adaptation and validation of vocal assessment and several developments of voice scales. From clinical guidelines to voice therapy during COVID-19 to study the attractiveness of dysphonic voices, his work consistently bridges the gap between technical measurements and the human experience of communication. When we discuss the button press paradigm, I still think a clever way to study voice and voice suppression with EEG by letting participants trigger their own recorded voice, Francisco didn't blink. He dove headfirst into the world of motor-related artifacts and the N100. He managed the crazy ideas behind setting up such an experiment for persons with Parkinson's disease, working with 2 supervisors of very different temperament, Jordi Navarra in Barcelona and me at Maastricht University. I leave it to the listener to interpret our respective temperamental traits. All along, Francisco brought his own clinical resources and a deep connection to the Chilean League against Parkinson's disease to the table. The adventure is far from over. We collected so much data that we probably can continue working together for years. Looking forward to this, Pancho. But Pancho is now also channeling the same, not shy to reach out energy into the next big leap. Just as a matter of fact, this morning he received confirmation that he secured a 3-year postdoctoral position through the Lundbeck Foundation to move to Denmark to work with the voice expert Boris Kleber in Aarhus. So this will allow you to dive even deeper into the neural ins and outs of voice change in Parkinson, and that's a fantastic result. The future is yours, Pancho. Now married, back in Europe, more energized than ever. We will know you will continue with your passion and ideas to push for the health and quality of life for people with Parkinson's disease. I'm happy that I could be part of your journey till today and in the near future. Enjoy your special achievement and the day. Congratulations. And before we clap, I want to give the word for 3 sentences to Jordi.
Well, I didn't prepare any speech, so, but yeah, so it will be from the bottom of my heart then, right? So I just want to, really to thank you, Pancho. Maybe I can call you Pancho for the first time because I always call him Francisco, and he complained. Yeah. So thank you so much for giving me the opportunity to work with you, together with you. I think that you have been very brave to do this work because you come from a specific background, and then you managed to learn very new things, like many new things in neuroscience, and including methods and many things, like how the brain works, no, or part of the brain works. So you did a wonderful job, I think, and you have been very, very creative. So you have your own ideas, and this has been great across these years. So all these years you have shown a lot of creativity, and I enjoy working with you because you are this kind of people that you are pushing things further all the time, right? So yes, I wanted to thank you and thank the members of the committee for evaluating the thesis, and so I'm very proud of you. So thank you so much. Yeah, thanks.
Thank you very much. Dear Dr. Contreras Ruston, also on behalf of Maastricht University, I congratulate you with the degree you have acquired. And before I officially close the session, I will just say we stay here a few minutes to make some pictures. And after that, we do a picture on the stairs. And after that, we will move to the area next door to the Refter for the reception. Thank you very much. I hereby close this session.
Right?
Yes, we wait
for the picture. Right? Yeah, there we are.
They have reappeared, yes.
Okay.